I'd like to get started by introducing your faculty. Your first speaker is Dr. Crystal Simone. She really is an esteemed scientist. She is extremely accomplished in the topic of nerve injury and really its effects on the musculoskeletal system, which is our goal today, is to communicate why it's so important to get these nerve injuries taken care of sooner rather than later. She has a PhD in biomedical engineering from Georgia Tech and Emory. She has worked for the biotech industry, multiple different industries, and currently works for Oxygen and is a real key component to their team. She has launched 2 different medical devices and has patented some of these medical devices, which is impressive. And she can put on a really good crawfish boil. And after Crystal, we all look pretty dull. Our second speaker is Dr. Brendan McKay. He went to medical school at Northwestern, did residency at New York University in Langone. He did a fellowship in hand surgery at the Center of San Antonio. He's currently associate professor, Department of Orthopedics, and also the director of hand and microvascular surgery. And he enjoys skiing, scuba, and golf. He sees a lot of traumatic nerve injuries from farm equipment and that sort of thing. Rob Gray, he went to medical school at Brown University, residency at Rush, fellowship at Mayo, is now in Chicago at North Shore Medical Center. And he enjoys family and is very elegant and enjoys English literature. So this is our group, and so on that note, we will get started. And Crystal, you are on, and I will stop sharing my screen.
Thank you, Dr. Mercer, for the kind introduction. It's really a pleasure to be here with all of you, and thank you to the ORS for supporting this great webinar related to a very relevant topic on nerve regeneration and why the timing matters, which is, of course, a critical topic as we think about the prioritization of patients in COVID-19 and beyond. Like Dr. Mercer said, I have a scientific background, so we thought we'd kick it off with more about the mechanisms of nerve regeneration and why the timing matters. And then the surgeons will speak about their clinical experience and some of the clinical literature. As a disclosure, I am an employee of Oxygen. This presentation will not include a discussion of any of our products. It's simply about the basic science, but worth mentioning that disclosure. So to kick things off, probably a good idea to just review some basic peripheral nerve anatomy, some of the components and some of the terminology we'll be talking about throughout this next lunch hour. So when we think about the peripheral nervous system, it's important to remember that the cell bodies are located at or near the spinal cord. So for motor neurons, they're located here in the ventral horn of the spinal cord. For sensory, they're located in the dorsal root ganglia, which is just outside the spinal column. And their axons extend all the way from the spine to the target organ. So the longest would be, for example, from the base of the spine all the way to the tip of the toe. So very long cells. In fact, they are the longest in the body. And this length really comes into play when we think about the timing issues and the timing factors related to functional recovery. These axons, like I said, traverse throughout the peripheral nerve sheath. They're surrounded by Schwann cells, and these are cells that provide the myelin that insulates the nerve fibers and allows the conduction to occur over such a long distance. These fibers travel in what's called endoneurial tubes, and the endoneurial tubes are going to be critical because they provide the structure and the extracellular matrix components that guide the regeneration. Those are then organized into fascicles, and then many fascicles make up what we know as the peripheral nerve. There are varying levels of nerve injuries that can occur. This was the classification defined by Seddon. This is in order of least severe to most severe, so starting with a neuropraxic injury. This is more like a compressed nerve where just the local myelin is damaged, and that results in a conduction block. So you can get a loss of function, but if, for example, you do a nerve release, this can return quite well, and this is the most likely to recover in terms of type of injury. Getting a little more severe is when the myelin is damaged and also the axon. This will take longer to recover because the axon has to grow from proximal to distal. But again, if the endoneurial tubes and extracellular matrix is still intact, there's a good prognosis. Even more severe, or the most severe, is the neurotmesis, which is where the entire nerve trunk is disrupted. And when you start to damage the endoneurial tube structure and the entire nerve, that's usually when a microsurgical repair is required. And that's when really the focus of today is talking about those traumatic nerve injuries and how to deal with them and how to prioritize them in terms of timing. If we take a deeper look at the mechanisms, here's a nice diagram just showing the sequence of events. So in the most immediate term, you see that there's a disruption of the signal, and that's just from essentially the axon no longer being connected between the cell body and the target organ. That electrical signal disruption is really what triggers an immediate loss of function, of course, because there's no more communication between the two, point A and point B. But this disruption is also what triggers an inflammatory cascade and some gene expression changes that will affect both the short and long-term phenotypes of the cells. Within hours, that inflammatory response starts to increase. It's more of a pro-healing, especially in the early phases of this, and the macrophages start to clear the debris, and there's something called Wallerian degeneration that begins. Most of the Wallerian degeneration occurs distal to the injury site, and so that's just, if you think about it, it's like the cell components distal to the cell body are no longer able to receive the proteins and the gene expression from the nucleus. So the body is essentially clearing it away so that it can create an environment where you can get regeneration. The critical components for that really occur in the following days, and that's when the Schwann cells start to change phenotype. They go from a myelinating phenotype into one that's more pro-regenerative. They start to secrete growth factors, they remove debris, and they convert the extracellular matrix to be more of a scaffold that is providing pro-regenerative proteins and glycosaminoglycans and clearing away the ones that are inhibitory to growth. Over time, these Schwann cells form what's called the bands of Bungner. This occurs within those endoneurial tubes, and so now you have structural components as well as biochemical components helping to guide axonal growth. It's important that the organization of the growth is linear because if you start to get sporadic axonal sprouting and misdirected axonal growth, what you end up with is fewer axons reaching the target and a greater probability that you'll form a symptomatic neuroma, which can result in pain for the patient. One of the most critical things when we think about the ability of the peripheral nervous system to regenerate is the local environment. There are favorable factors that can occur, which is having good vascular supply, that organized matrix scaffold, the basal lamina tube structure, the Schwann cells, all of those things are critical. And of course, you want components that promote growth and fewer components that have growth inhibitors. So a mature peripheral nervous system, if you think about it, it's more like hardwired. The body wants to maintain the connections that form during development. When there's an injury, it reverts back to more of what you see in development, where the body is trying to generate those connections and create an environment where the neuron is able to find its target, and a lot of that has to do with the cell phenotypes and the components of the extracellular matrix. So we see sort of a reversion back to developmental mechanisms in the peripheral nervous system. Unfavorable factors would be chronic inflammation, scar tissue. Axons don't like to grow through scar. So it's really important to do a proper debridement if there is going to be a microsurgical repair indicated. This is probably the biggest thing that surgeons can control. We call it the 4 T's. So number 1 is timing, of course, the topic of this webinar, and so I'll let the surgeons elaborate on that in their experience. Number 2 is trimming, so that it's really important to debride until you reach healthy nerve tissue. That microenvironment, the basal lamina tube structure, the components of the laminin as opposed to the dense collagen is going to be important for getting as many axons across as possible and making sure that it's organized to reach the target. Number 3 is tension. Tension-free repair is one of the dogmas of nerve surgery, and the rationale is that if you stretch the nerves out, these blood vessels, they start to collapse, and that's going to minimize the blood supply and ultimately inhibit the amount of regeneration that can occur. Number 4, the 4th T is technique. So that is just using good microsurgical skills and an appropriate bridging material. So, so this is really the things that we as surgeons and scientists can control, because there's a whole lot of other factors that are happening by the body that we may not be as much in our control. Some of the best studies on these mechanisms have been done by Tessa Gordon's group. She's a wonderful scientist out in Canada. She has done amazing work to really further this field. She wrote a review paper back in 2013, and here's an excerpt from that where she characterized changes in gene expression at both the neuronal level and the Schwann cell level. These are based on animal studies. So while we'd expect the same trends to occur in humans, we're really more reliant on the exact clinical outcomes rather than being able to study these mechanisms in such detail. But the premise of her work and the work of others is that there are gene expression changes that occur as a result of the injury. The body starts to upregulate pro-regenerative signaling molecules, neurotrophic factors, adhesion molecules, things that will extend the cytoskeleton, so more immature fibers that results in axonal sprouting, and again, just trying to find that distal target. And it starts to downregulate neurotransmitters because it doesn't need those anymore. It's no longer connected to a target, and the more mature neurofilament. And so these genes that go up are generally called RAGs, regeneration-associated genes. And in her work, she was able to characterize the fact that it peaks at about 7 days, and then at about 30, the gene expression changes. The mRNA changes extend for much longer than that, but you're still looking at 60 to 90 days before it goes back to that mature phenotype. So that is certainly involved in when we're thinking about timing, the fact that these gene expression changes are transient. With motor injuries, it's quite a bit more complicated, and it has to do with the motor end plates and the fact that these end plates can become less receptive to innervation over time. The seminal work on this was done in World War II, obviously dealing with a lot of injuries. There was a lot of interest in how to help some of the soldiers and treat them, or at least understand some of the mechanisms. And this was a rabbit study where they looked at denervated muscles, and they looked at the number of months of atrophy, and they showed an experimental change where over time the end plates, although the axons were able to reach the target, there was no functional connection being made to the end plate. So that occurs much more profoundly with motor, less so with the sensory, and so that becomes a really critical factor when thinking about these timing issues. The other thing muscle has going against it and motor injuries is the fact that atrophy can affect the functional recovery. So if something is innervated, a muscle is deinnervated, it's not going to be put into use, which leads to weakness and atrophy. This is a mouse study where they actually they cut the nerve and then weighed the muscle over time, and even within 1 week, there was 50% loss of muscle weight, which was statistically significant, and then at 8 weeks, they were at 32%, and so again, even if you get regeneration to occur, the end result of the function is going to be affected by this atrophy that occurs over time. In humans, one of the best examples is looking at, for example, carpal tunnel and looking at the wasting that occurs, again, from that chronic denervation. So this just really emphasizes the differences between sensory and motor. And if that wasn't enough, we also have to think about the distance from the target. We're always going proximal to distal in regeneration, and so the location of the injury is going to have an effect on how long it takes for functional recovery to occur. The rate of regeneration is pretty slow. It's 1 to 3 millimeters per day, and that's because the proteins that are being made by the nucleus have to travel all along the cytoskeleton, right, and reach and extend those axonal fibers, and that's the rate-limiting step in the regenerative process. So if we do the calculation and look at a median nerve at the wrist, it's about 100 millimeters or 100 days at best to the denervated hand muscle, and the plexus, you're looking at about 800 days. So that's just one more thing to think about. Again, makes motor a little bit more complex, and that's why some of the outcomes that you'll see, this explains a lot of the mechanisms. So in conclusion, that was just a summary of the basic science that's been explored on this topic. Just want to reinforce the importance of timing, and I look forward to hearing the comments and data and clinical expertise of the surgeons.
So Dr. Simone, you mentioned the amount of lost motor end plates at the 8-week mark. What happens after that, and how long do you see this denervation process?
Generally speaking, that is an irreversible change. The fact that the end plates are no longer receptive to the innervation. And actually, if it goes much longer than that, you can also start to see longer-term effects in the cell bodies where if they can't find a target, the neurons themselves will actually undergo apoptosis and die. So it actually has almost like a positive feedback effect where it just gets worse with time.
And do we know those time periods? I mean, I know this is sort of a nebulous question, but do we know the period where that happens and where you no longer are going to get any function back?
The translation to humans is, pretty tough, I would say, and that's why we just rely on overall outcomes data, unless some of the surgeons are able to comment on their experience. That might be a better question for them.
Yeah, I found that probably 18 months is the cutoff, it seems to me. I mean, I've tried some pretty heroic adventures in nerve reconstruction and neuroreconstruction, especially in young people with the hopes of getting some of their physiological function back. But I've found that typically 18 months seems to be the point where you're probably get much back. But I mean, I don't know if that's exactly accurate, but just from a clinical experience standpoint, Dr. McKay or Dr. Gray, have you seen anything different than that?
I think there's some possibility that the sensory can go a bit longer, and there's data to support that. We'll talk about that. And frequently I reconstruct outside of the normal window for motor reconstruction for two particular reasons. One, I think reconstitution of the nervous system lets the brain know that it's complete, and I don't seem to find people with as much neuropathic pain when it's reconstructed, even if they don't get a functional outcome. And secondarily, especially in young patients, I think giving them a shot at sensory recovery, and I have seen in an ulnar nerve, up over 2 years in which we've seen some recovery or the patient reports their sensibility has improved. So I don't have an exact time frame for you, but those are my thoughts.
Yeah, and that's more neuroma management, which is a whole different topic and a really serious problem. Dr. Gray, anything to add to that?
No, I would. Can you guys hear me?
Yes.
Oh, good. I'm sorry, I've been having some computer issues. No, I'd agree. I'd say, a year and a half, 2 years is sort of your pushing the outer limits. But, I always give it a go at reconstructing the nerve deficit. You never know. I mean, nature is awesome. I let the master surgeon do her thing, and she's much better than I am.
And that's my rationale, right? So, even if it's a radial nerve or ulnar nerve injury that presents delayed, we live in a remote state, people think it's going to get better. They don't come in to see me for a year and a half, which is a little mind-boggling. But still, management of the neuroma is important. The sensory thing is important. And so, I mean, to me, anytime that I see somebody that is less than 18 months, like that is almost, in my book, kind of an urgent thing that doesn't have to be done tomorrow, but it really should be done within the next couple weeks. And so that's kind of how I manage my clinical practice, is that I just do not delay those patients any further.
So I think one other thing that bears consideration a little outside this talk is when you have somebody who presents in a delayed fashion and you don't necessarily expect, based on the timing with regards to their injury, is that acute nerve transfers concurrently. So I think probably we haven't really defined the algorithm perfectly yet, in the sense that repair, transfer, sometimes I even do some type of static or dynamic reconstruction at the same time. I've started to do volar plate advancements very early, which is an old school way of dealing with clawing. But if you know that you're going to get some weak intrinsics back, doing that earlier actually allows their rehab to come back. So I think as we continue to go further, we're going to start to revisit this in a much more holistic way than we ever probably have in the past.
Yeah. Good. So Dr. McKay, you want to proceed with your talk? Thank you,
Sure.
Dr. Smith. Awesome as always.
I just wanted to make sure I made an adjustment. Is the sound okay, Dr. Mercer?
Yeah,
reasonable?
Yes.
Okay, excellent. Okay, so I'm about to share my screen here. Okay, well, thank you to ORS and to Dr. Mercer for inviting me and for my colleagues being available. So here are my disclosures. We're not going to speak about anything pertinent to this directly. So a few of these early slides overlap with Dr. Simone, and so we will not kind of go into them in detail, but essentially, obviously, there's a variety of nerve injury patterns, and usually that classification then correlates with your treatment and what your expected outcomes are. So in less severe injuries, generally they do better. Worse injuries do worse. Large nerve defects need a lot of time, and you have to deal with denervation. Obviously, in the distal stump, these endoneurial tubes have to be receptive to allowing the nerve to grow through it. And with time or severity of injury, this may not be as good as it would be with a less severe injury. So obviously, we have end organs that we're trying to reinnervate, and we have to deal with whether or not they're going to be available by the time that the nerve regeneration gets there, and that seems to be more significant with motor than sensory. It seems that somewhere in that 18 month to 2 years is definitely the motor cutoff. Sensory, as far as I've been able to tell through extensive reading, it's not clear, but they say it potentially could go 2 to 5 years from what I've seen. I don't know that I've followed someone out for 5 years, so I can't say much to that. Dr. Simone has already spoken about when you're having neuronal cell death, but I think one thing that wasn't touched on is that obviously this is not just the nerve, this has to do with the brain as well. And so when you have chronic nerve problems, whether they're reconstructed or not reconstructed, you're going to end up getting cortical changes. And those cortical changes are frequently going to dictate how the patient perceives their reconstructed or unreconstructed injury. So obviously, you know, peripheral nerve injuries can either give you poor motor or poor sensory if they're untreated. And the big deal is, you know, loss of function and or chronic pain. And in the real world, which is mostly what I do because I have a very busy clinical practice and my academic stuff is kind of after the 6 o'clock hour, we deal with high cost, lost work, medical disabilities, pharmacologic dependencies, expenses, difficulties with finding doctors to believe what is real versus not real for these patients. And it really can become a complex issue that it takes time to sort through and really identify what's going to help patients. So there is data out there that compares untreated nerve injuries with those having gone operative intervention. And so if you look at the top portion of this, this was a look at people who did not get repaired after their nerve injuries, and this essentially created some baseline data. And we have these follow-up studies which look at whether or not treating them actually improved their disability or their outcome. And so some of the studies overlap in terms of their confidence interval with the original study, showing that maybe they don't add that much. But the newer studies, which you'll see at the bottom, show a significant difference in their mean disability score. And even with their standard deviation, they're showing improvement compared with untreated. So I don't think we have to convince most people that are in the audience today that treating nerve injuries usually gets you a better result. But I think when you talk to a broad group of surgeons, neurosurgeons, hand surgeons, orthopedic surgeons, there is some dogma out there that generally nerve injuries just don't do well. And sometimes, is there any worth to trying to reconstruct something, especially that's complicated? My answer is yes. Obviously, I have an interest in it, and I do a lot of it. So what is our current reality? Well, it's 2020, and obviously this is a weird year and a weird time, but we have not gotten a definitive paper at this point that consolidates the evidence regarding timing of nerve procedures, and that's kind of unbelievable to me. And after some discussion with my colleagues, we decided that it was time to look at this, and obviously the current events, including COVID, made this a bit more apropos, given that we were talking about timing and when to do things. So what did we do? Well, the research group and my research coordinator, we extensively and critically reviewed Medline and Embase, and we looked for publications that would help us understand effects of timing in nerve surgery. We went through thousands of publications. 209 of them were deemed relevant. The article hopefully will be in press relatively shortly, and you can read a little bit more about the specifics of how we conducted this search. So what did we find? Well, in importance of timing, a study of 66 median and or ulnar nerve lesions found that a delay period was most significant prognostic factor in functional nerve recovery. So many reports describe negative impacts with greater delays. And so essentially what you find, and obviously because we're speaking about it, is that timing is critical in your treatment algorithm. So obviously we're talking sensory and motor are not the same, even though they're both nerves. And so let's talk about these more specifically. So clinical data suggests that sensory nerves may be less affected by prolonged denervation than motor nerves. And again, this likely has to do with the ability of these end target organs being reinnervated and whether or not what they send to the brain after reinnervation is amenable to a functional response. Interestingly enough, though, the histologic response appears to be amplified for sensory when compared to motor nerves post-injury. So there is a little bit of confusion as to why there seems to be more inflammation and kind of a more robust response in sensory than motor, and yet we do see longer sensory recoveries because typically we think that unchecked inflammation is not very good for nerve recovery. So obviously recovery of mixed and motor degrades over time dramatically, especially motor. We all know that. And the end organs are not available to accept reinnervation probably after 18 months. So there was a systematic review of 270 mixed nerve injuries. You can see the breakdown.
A question. Is it okay
Yes.
if we ask you a question?
Yep.
So what is the evidence out there with respect to immediate versus delayed, talking weeks?
We're going to get there. So hold on. Let me go back here. So in this, and again, this is not, the whole goal of putting this together was not to be opinion-based, right? So this is not reflecting my opinion. This is just reflecting the actual good data we have. And you can see the reference numbers, and I'm happy to provide that complete reference list to anyone. If you contact ORS or Dr. Mercer, we can give you this so you can look at the particular papers. But if you look at this systematic review, right, so excellent sensory recovery, 90.9, immediate repairs, less than 24 hours, 58% in less than 1 month delay, 73% in a 1 to 3 month delay, and 46% with greater than 3 month delay. And so some studies have reported increments as small as 14 days for progression and functional decline. So that means that if you're not getting it to it immediately, every 14-day window that passes, the patient is going to do worse. We don't know that in a randomized controlled trial, but based on the evidence that's there, this is what we're seeing. So in the same review, good to excellent motor outcomes were achieved in 85% of immediate, 80% in less than 1 month, 71% in 1 to 3 months, 52% in 3 to 6 months, and 25% with greater than 6 month delay. And this is not taking into account adjunctive procedures. This is just a primary repair or some type of reconstruction. So when we look at it, for each month of delay to repair, there was a significant decrease in the odds of good to excellent motor recovery, and you can see the data there. So there's also some additional data besides that study, 260 radial and PIN nerves, good to excellent outcomes in 49% within 14 and 28% of late repairs, a mean of 190 days, but obviously the range is quite large. 82 musculocutaneous nerve injuries, good to excellent, we saw good to excellent if they were repaired within 14, and then that dropped off again after 14 days. So, you know, when I give talks, I like to have take-home messages because, you know, my attention span sometimes wanders. So here we are. Repair within 14 days when possible. If the initial presentation is delayed, we suggest to repair within 14 days of the clinical presentation, if less than 6 months from the time of injury. After 6 months, we're still going to reconstruct the nerve, but you're going to have to think about it in a more holistic way, as we said, with either transfers or tendon transfers or nerve transfers or something else that may try to improve your overall outcome. As we know, functional sensory return is probably not as time sensitive. And while sooner is better, basically we may be able to get some type of recovery in a delayed fashion, but it really is not well explained. So for the mixed motor, immediate repair within 24 hours. If initial presentation is delayed, again, 14 days within clinical presentation because of that time frame. We've actually seen the data for the motor. We looked at 30-day increments, but we're hedging our bets a little bit and recommending that you try to get to this within 14 days so that you're going to stay outside of that next interval. And then after 6 months, again, you're going to have to think outside the box a little bit because probably a direct repair is not, or even a reconstruction is not going to get you what you want. And then we obviously know about the motor end plates and the slow rate of reconstruction. So even though we've now talked about sensory and motor, digital is actually considered a different animal when you look at the literature. And, some people may say, well, it's just a sensory nerve. Well, it is a sensory nerve, but it appears that maybe they're a little bit different. And obviously they're of a critical importance compared to some other sensory nerves. So, if you have an abnormal sensory outcome, it's frequently these patients don't have normal motor function because we know that there's a stereognosis is a really important concept in being able to identify things with sensory input to the brain for which then you respond with motor, right? So patients with good active range of motion on clinical exam, if they have a sensory deficit, they may actually not move the digit well because the brain is not getting feedback that's telling it to incorporate it. And they may also have some pain. And as a result, we know when that digit's not being used, it now gets in the way or sticks out. And so they can have a worse outcome than they would have if this finger is not integrated into cortical function. So pain secondary to neuromas is also really important in the digits and also in the feet because we are putting pressure on our hands and our feet, and those neuromas are not under a significant amount of soft tissue. And so we have to be even more diligent about neuroma prevention or just the recognition that this could interfere with someone's function. So there's quite a few studies. As you can see, there's about 25 studies that all support time to repair in less than 15 days has been associated with significantly improved sensory outcomes. There's another study with 254 digital nerves that said that you could delay the treatment. But again, I think the burden of the evidence is suggesting that repairing these within 2 weeks is better. So again, here's your take-home messages. Acute repair within 14 days of presentation. If it's delayed, you want to try to get to this within 3 months from injury. After 3 months, you're obviously still going to repair the nerve, but again, you may have to think about adjunctive techniques. And again, we're hammering on this, but motor versus sensory is important. I probably get quite a bit more heroic in mixed and motor nerves because I'm trying to potentially get them some sensory, knowing that they're not going to get any motor back. So obviously what we've discussed so far is important data, but we don't operate on patients in a vacuum, and the literature is only as good as all of the variables that we have to take into account. So you need to think about some additional things for each patient, right? Ability to achieve tension-free repair, operative time required for each repair approach, especially in the face of a patient's overall well-being, ability to reduce anesthesia acuity and duration, management of your nerve gap, resource utilization, things like, and that was obviously in this COVID is important, but it can be important in other situations, insurance, socioeconomic status, likelihood of returning for secondary procedures. In a lot of my practice, these patients are coming from hours away, have very limited insurance, and sometimes I'm forced to try and do as much in one sitting or one hospitalization as possible because they may never get back for additional surgery, and you have to think about that. Management plan for concomitant injuries and procedures, almost none of these I do are in isolation. Almost all of them are polytraumas, and you've got to talk to your colleagues who are doing other work to figure out the timing and order. Extent of the rehabilitative plan, because you can do the greatest work in the world, and if they don't get rehabilitation, you may end up still with a pretty poor result. And I'm in a tertiary referral center, but if you're not, or they have to travel to you, you've got to take that into account. So finally, one other thing that kind of gets outside the scope but is very important, is obviously patient desires do not always align with scientific evidence for optimal timing, right? In practice, you've got to engage the patients in informed discussion. One of my mentors, Chris Peterson, always said, you've got to size up the patient, got to talk to them, find out what they want. And the right decision for one patient is not the right for the other. And it may not feel right to you, but the reality is each patient is going to want something different potentially. And obviously a developed understanding of these relevant factors. You got to create this comprehensive plan, and you got to take time to kind of sit down and get to know the patients you're dealing with, which actually can be one of the more rewarding things. So thanks for the time. Hopefully that was helpful to y'all. I'm happy to answer any questions here, or please feel free to contact me via email.
So Dr. McKay, what if you're in like post-injury day 2? There is some literature out there talking about sort of the magic of the first 72 hours, which if you get to them within that time frame, it's almost like getting to them in the acute setting.
Yeah, I would say that is not a common situation for me. I either see them when it happens or I see them weeks later. So we didn't spend a lot of time on that. But if someone obviously comes into you, especially with something like a median nerve laceration at 24 hours or 48 hours, that becomes an urgency. And that's something that I'm going to take to the operating room, as soon as possible, if not that day, within the next day or so. And you have a great point there. Unfortunately, I think the reality of the world is that's not a situation I see too often. But definitely people in private practice may see it because there's good access, and someone may get into you fairly immediately, right? So definitely a good consideration.
Thank you. Excellent. So bottom line is get to it as soon as possible. But we all have constraints, and the constraints of the medical system is also difficult when we're doing these cases. They come in at 2 o'clock in the morning, and then you're doing the case at 2 o'clock in the morning the next day because there's no OR availability, right? So those are also challenges that come up with respect to taking care of these people efficiently, which, every day we're working on that efficiency. So Dr. Gray is up, and he's going to give us a couple case examples of patients that presented delayed with nerve reconstruction procedures done and their outcomes. And I think we've got a good couple cases with good long-term follow-up. Dr. Gray, you're up.
All right, very good. You guys can hear me?
Yeah.
All right, so let me share my screen. This. Let's see if I make this work. Okay. I'm better at surgery than I am at computers, I promise. Okay. Let's see. Share screen again. That looks good. Okay, do you guys have my screen?
Yes, we can see it.
Okay, all right, very good. So I've just got a couple cases. I'm not nearly as high volume a neurosurgeon as you guys are. Most of mine are boring, digital nerve here, digital nerve there kind of things. But then there are, a couple every once in a while where I have some follow-up that are good. So nothing relevant to disclose for this talk. So this first case is a 23-year-old guy, fell off a cliff, polytrauma, all kinds of disaster, head injury, broken bones in the legs, but actually came out like a daisy, smelling like a rose, and presents late with, something's wrong with my hand. It's not working. I can't feel my thumb and my index finger. I can feel the middle finger some, but something's goofy. So, with this history and the polytrauma, that we knew there was something wrong with the median nerves, and the decision was made to take him to the OR. And you go and you see 7 weeks of neuroma staring you in the face. And so there's some nerve incontinuity, which explains some of intact sensation, but then we lost motor and we lost sensation with the thumb and the index finger. And you get in there and you zoom in and you say, all right, well, that's not good. There's a couple cells hanging in on that, but we got to clean that up. So as we discussed, you need to have You need to trim it. You need to have attention-free repair. So this is what the neuroma looks like on the green towel. Looks sort of like teeth to me, but my wife is a dentist, so I'm biased. But what you want to see once you clean it up is you want to see good, healthy, blooming fascicles. You want to be able to look, and it should look like a bunch of spaghetti or capellini that you're about to throw in the pot. You should see individual things. If it still looks flat and like one smooth layer, you haven't done enough trimming. You got to get back to something that's going to heal and something that's going to allow healing to come to it. And however big a gap you have is however big a gap you have. And you can kind of keep sectioning with an 11 blade or a nerve cutter ideally until you get to that. But that's kind of what it looks like when you're staring at it. So, you know, I tend to be an off-the-shelf person for most grafts if I can pull it out of a box, do it, then I know a lot of people disagree with me. Ranger study tends to support this for sensory and even for mixed motor deficits. I personally like it better, and you're not causing another deficit. So this gap is, 2.5, almost 3 centimeters. Nerve graft is used. Wrap it and wrap the dinged but not cut nerve too, to also prevent scarring and neuroma. And then you kind of keep your fingers crossed. And so at a couple years, two years later, he's got intact opposition of the thumb. You can see the thenar bulk is, improved. It's not perfect, but it's not hollow. And, AIN function, DIP may not be bending all the way, but I mean, that's reasonable. That's a very, very good outcome for a nasty injury. And again, it's 7 weeks. So we're definitely past the acute window. Another case I've got is a really nice 11-year-old kid that my P's partner fixed. He was bouncing on a trampoline in one of these parks. This is actually a picture from the website, by the way. So I'm like, this does not sell trampoline parks to me. But he gets an open both bones forearm fracture. And, as you might expect, he's got in a lot of pain and anxious. But something's wrong with the nerves. You can't tell exactly what. Median is a little weird. Ulnar is a little weird. So they take him to the OR that day for washout and fixing him. And so you can see the injury films, and you see this horrible spike of the ulna where it, peeked through the muscle envelope and didn't make it all the way back in. And that sort of long oblique, almost Holstein-Lewis, esque fracture pattern to it. That's a nasty looking fracture pattern. So he's taken the OR and did the radius close with a nail, and then opened the open fracture at the ulna, extended it, got a good look, made sure there wasn't anything scary in between the bones, and then rotted that. And then he's coming back to see my P's partner, and his hand is progressively getting funny. And she's like, "Come over here one day. His hand is looking funny." And so at about 2 months, 2.5 months, his hand is just looking flat, and the fingers aren't moving, and he's numb. So I said, let's send him for an EMG and let's ultrasound them. So the EMG shows, awfulness, like really bad ulnar nerve, really bad median neuropathy, and actually like a little bit of a sensory mononeuropathy in the radial nerve, even though that clinically was fine. And so, all right, well, let's get some more information, because I could believe ulnar nerve getting taken out with the fracture, but median nerve doesn't make any sense. So we did ultrasound of the nerves. Median nerve looks fine on ultrasound, but there is some discontinuity, or certainly something where you can't quite follow the fascicles all the way in that kind of proximal mid-third junction of the ulnar nerve. And so that, and the EMG and the clinical exam and that x-ray, I felt obligated. We had to give this kid a better chance. So I took him to the OR. And so this is what his hand looked like pre-op. It's that horrible, flat, shiny, he's losing the arch. If you look at my marks right there at the open fracture site, that he's got a good tunnel in the ulnar nerve distribution there. He's got a tunnel just proximal to the carpal tunnel over the median nerve. And he's got that horrible claw going on. And so in the holding area, I'm putting him through his paces. His intrinsics are just not doing anything. I'm asking him to make scissors here. He can't cross his fingers. He's got intact radial for sure. And the deep finger flexors are working. Radial nerve is working. But, I try, can you oppose? Can you touch your thumb over your pinky finger? And that that's as good as he gets. He's cheating with FPL and then using the bed rail. So that's not getting it. So what did I do? So I took him to the OR. I'm a big believer in releasing nerves above and below where you fix them. So I like a scope cubital tunnel release. I like an anterior transposition on the ulnar nerve, buys you some length, maybe shorten the amount of graft or eliminate a graft if you need it. And then I turbocharged him with AIN to ulnar motor transfer, did the carpal tunnel release and Guillen's canal release. And so I don't have good intra-op photos on him, so I stole these. But this is the motor fascicle, the median nerve being exposed. I use this, proprietary, endoscopic cubital tunnel system to do it. I get good release up and down. You can use whatever you want to do, but you can see how high up I typically go for the release. And so that nerve is really freed up. I get the arcadis struthers release, and you can see the vascular markings popping back in the ulnar nerve once you release that. And then I examined the ulnar nerve, and he had like an 85% lac with some neuroma in there. So I cleaned it out, and I put a allograft in there, and I wrapped it, and I did the sets transfer. So AIN motor to the ulnar motor, and then released the carpal tunnel and released Guillen's canal. We pulled this hardware out and kind of kept our fingers crossed. And then you just kind of hurry up and wait. And this is just a picture of how I do Guillen's canal. I go through the carpal tunnel incision, and you got to get that deep motor branch really released underneath the hypothenar musculature too. I think that's very important. And so, kids make you look good. So 6 months from the injury, but 4 months from the surgery, he was actually starting to learn how to write with his left hand because he couldn't write with his right hand at all. So, sassy kid. We're going to watch his fingers work. And so his intrinsics have come back. So the opposition is still weak, you can see, but he's got a more normal shape to his hand. And his radial nerve is back, or his radial nerve is never out. And then follow the same kid out, same t-shirt. And so this is 9 months after the injury, but 7 months after surgery. All right. So better lucky than good. I listen to people smarter than me, and I kind of fix the things how they tell me to. And, with some of these good techniques, you can have some pretty good outcomes if you're lucky.
Great. Those are incredible cases with incredible outcomes. So one question about length of reconstruction. What are your thoughts on length of reconstruction? You talked about trimming back to budding fascicles. We know that's so important. You can't sew scar to scar because it does not regenerate. What are your thoughts on length of reconstruction, especially in the delayed setting?
Yeah, shorter is better. The ideal nerve is a nerve that has never been cut or injured, right? We don't have that. Everything that's closer to that is better. Everything that's further from that is worse. I couldn't give you like a real good cutoff. 7 centimeters, you're really at, hope and a prayer kind of territory. But what are you going to do? You try it. Now if it's been 17 years and it's 17 centimeters, okay, maybe you don't put somebody through that in the expense. There does get to be a point where it gets ridiculous, but you got to use your judgment.
So Dr. Mercer, if I can pipe in on that one. So I actually have an interest in long graft repairs. We presented some data at FESH, the World Hand Surgery Meeting in Berlin last year, and we don't have a huge amount of data, and really no one does. There is military data that shows that you can actually get N3 recovery in reasonable sensory for up to 14 centimeters. And that's not published because of some limitations in the military, but the reality is it's been done by some very competent people. So in acute trauma in the right patient that has low comorbidities, I will be aggressive. I think, the gold standard, depending on who you ask, but if you poll people, they would say over 7 centimeters that you should be using autograft. I think it's something you definitely have to think about. A lot of times these large gaps are in bigger nerves. You may need autograft, allograft, a combination. And so I don't think there's an answer, but I think there is data, unfortunately, that's not readily available that suggests that you can go bigger. And if you've ever watched Dr. Bunky cut back a nerve, I think it stresses you out the first few times you see it. But the reality is go bigger, go home, go Texas style, because garbage in, garbage out, you need 75% of the cross-sectional density of your axons to cross your gap. And if you don't, it wasn't worth trying to do the repair. So, that's kind of my take homes on that one.
Yeah, and I agree with you, especially, these terrible polytraumas where the nerve is left on the side of the road and you have a big giant gap with, dirt and grass and fractures. And in those situations, I agree with you that there's no harm in reconstructing. And if anything, you at least don't get a neuroma. And
right.
So even if you don't get sensory motor recovery, you can at least prevent the neuroma formation because you're giving the nerve somewhere to sort of grow into. And so, especially in our patient population here, we have a lot of motorcyclists that, love our wide open space. And to me, it's better to give them a chance at some recovery than to leave a 12 centimeter gap in a nerve. So, and again, is that supported by literature? Probably not solidly so, but we have our clinical experience, which, as you mentioned, we don't have a ton of these cases. And, the long-term follow-up is also not really there. A lot of these patients don't come back, which also makes it very difficult to understand what happens long-term. But to me, if you have the ability and the equipment to do it, I think it's reasonable to do so. So one last question: what about the mixing the motor the nerve auto with allograft? There has been some discussion that almost it brings in maybe Schwann cells, even though you resect the nerve into and bring it across the room from the back table and then put it back in. So how has that changed if anything, changed the way that you treat complex nerve injuries? Do you use that concept of auto with allograft?
Despite all these big segmental deficits I have, luckily I don't see tons of sciatic and femoral and all these other ones, which are usually where you have to start thinking about that combination. But in talking to a number of people, who have more experience, they do advocate that additional. There's also work coming out of VCU, Dr. Isaac's group, that's even looked at these end-to-side nerve transfers into the allograft, providing Schwann cell highways. So the reality is I don't endorse any one particular way. I think you have to think aggressively about the biology and how to improve it. And so without an abundance of data, I agree that you got to give them the best chance. And that usually means providing some of their own tissue. But sometimes, as we all know, there's just not enough autograft to go around, Yeah,
good. Crystal, anything to comment from a biology standpoint on that?
Just that I think the concept of adding cellular components to nerve grafts is very interesting, and I think that there's a potential future for it. It'll be interesting to see the studies. We've been working with the DoD on some grants to look at other cell types as well. So always looking for innovation and pushing the envelope. The clinical outcomes will be interesting to see, and we look forward to that. And I also think back to what Dr. McKay said about really involving the patient in that decision-making process. And, are they willing to have a sural nerve harvested, knowing the potential pros, the potential cons? I think that's really critical. In lieu of the clinical evidence, it seems like involving the patient in that decision-making process would be really wise.
Great. Brenda, I think we're out of time, but that was really great.
Yeah, thank you. Thank you so much for organizing this, Dr. Mercer, and to all of our speakers. Thank you so much for participating in the session today. We had a very good participation rate. We have recorded the session and we will send it out to all of the participants of this session within about 48 hours. If you have any questions, please contact our office or please leave us a note in the chat. Thank you so much.
Thanks, everyone. Have a good day.
Have a good day. Thanks, everybody, for participating. Thanks to the speakers.
Thank you all.